Welcome to the quarterly Airway Research Update with Dr. Calvin Brown.
Great, thanks Terry, and hello everyone. It's great to be here with you today. My name is Calvin Brown. If you've listened to our webinars before, then you know where I'm from and what I do, but for those of you who are new, I'm an attending physician in emergency medicine at Brigham and Women's Hospital in Boston, and associate professor of emergency medicine at Harvard Medical School, and the course director for the difficult airway course Emergency. Today's webinar will include 3 new studies and a clinical vignette. We encourage everyone to post comments and ask questions. You will also be invited to participate in a few polls related to the vignette. I will take questions hopefully throughout, but predominantly we tend to do this at the end, but you can post questions at any time. I have no official CME disclosures, but I thought you might be interested to know about the other disclosures I have written in the box at the bottom. This webinar has been approved for 1 AMA PRA Category 1 credit and 1 hour of CAPC advanced credit. Everyone in attendance will receive a certificate by email within 3 weeks. This webinar series will keep you up to date on airway research and help you apply the findings to your practice. The agenda is very similar to our other webinars. We have a pretest, a research review, and this time it's 3 studies, Q&A, really at any point, post-test questions, and then an evaluation upon exit from the presentation. So we're going to get started in just a second with our pretest, but before we go any further, we want to have some well wishes go out to one of our loyal followers, Bill from Boston. Bill, we hope that you have a speedy recovery and get well soon. Okay, let's move on to our pretest. Now the pretest is really just to get an understanding of everyone's baseline knowledge on the topics that we're going to review. And then the hope is that by the end, when you take the post-test, which is going to seem very similar to the pretest, that if there's improvement to be had, that we see that improvement. All right, so here's pretest question number 1. In the emergency department, angioedema requiring intubation is primarily managed with which of the following tools? A, hyperangulated VL, B, flexible intubating bronchoscope, C, a direct laryngoscope with a straight blade, or D, a cricothyrotomy kit. Alrighty. Now, I don't tell you how everyone is answering just yet because I'm not supposed to tell you so it doesn't confound the post-test. All right, so let's move on to pretest question number 2. Which of the following is true about awake intubations in the ED? A, most are performed by non-EM specialists. B, they represent 3% of all intubations in the ED. C, the orotracheal route is most common. Or D, airway obstruction is the most common indication for awake intubation. I'll go to pretest question number 3. All of the following are indications for an awake intubation in the ED except which of the following? Significant anatomic distortion, predicted rapid desaturation, poor preoxygenation due to intrapulmonary shunt, or the need for an immediate intubation. All righty. And let's move on to the last pretest question. On awake intubation means the patient is A, intubated without medication, B, intubated with sedation only, C, intubated with topical anesthesia, with or without judicious use of sedation, or D, intubated with heavy sedation but only small doses of a neuromuscular blocking agent. Thank you for answering. So let's get started. As we mentioned, we have 3 new studies today. We have a clinical vignette to facilitate discussion, and the topics, as you may have guessed from the pretest questions, we're going to talk about awake intubation. We're going to talk about decision-making for awake intubation and the algorithmic approach to the predicted difficult airway. Now, before each webinar, I receive from our crack team at the airway course a list of generally 40 or 50 airway-related studies, and I scan that list, and as I come up with the handful of papers that I think are worthy of discussion, I try to put together a theme. So 3 papers on pre-hospital airway management, for example, 3 papers on surgical airways, for example. And for this one, we're going to talk about the nose. This is an airway webinar about the nose, what the nose can do for you, and how the nose can be used as an avenue to facilitate tracheal intubation, and in which situations the nose should be used. So let's move on and talk about the nose. And we'll start with a case presentation. So you are working in the emergency department and you receive a call from EMS. They're bringing in a patient who has tongue swelling. So when the patient arrives, you are presented with a 72-year-old man, history of difficult to control hypertension on multiple medications, type 2 diabetes, and peripheral arterial disease, who is coming in now with about 1 to 2 hours worth of tongue swelling, which has been progressing to the point where he now is starting to feel a choking feeling in the back of his throat and is now starting to feel short of breath. His room air saturation is 94%, and his other vital signs you see there. A little hypertensive, a little tachycardic, and a little tachypneic. So this has been going on for 60, 120 minutes, but he's starting to get some more serious symptoms, which prompted his call to paramedics, who then brought him to the hospital. He is speaking in full sentences, but his voice sounds somewhat garbled. Introduce Google image of angioedema. So you can imagine this is the patient. If you happen to live in a cartoon world, same thing. It's what it looks like on Saturday morning, for those of you who remember Saturday morning cartoons. All right, so you plan on intubating given the patient's progressive symptoms and now dyspnea. The patient care assistant asks, which tool do you want? And that person presents these 3 options. Do you want a flexible bronchoscope, hypercurve VL, or a scalpel and a bougie? So now I think you'll be able to see the results. So 72% want a flexible bronchoscope, about 20% want hypercurve VL, and 10% of you want a knife. All right, well, let's see what is used in real life. So let's talk about intubating patients with angioedema, and specifically in the ED. First paper we're going to look at is, this is pretty straightforward, emergency department intubations in patients with angioedema, which happens to be a report from the National Emergency Airway Registry. So we've done NEAR papers before. For those of you who are new, NEAR is a multi-center observational registry of ED intubations. We've had as many as 30, but on average about 25 centers contribute to the registry. And at the time we did this analysis, and this was published about a handful of months ago, maybe at the beginning of the summer, I can't remember the exact date. We had 3 years worth of data at the time, and we looked at a N of 19,071 intubations. And then with the database, what we do is we query it, and for this particular paper, we queried it specifically for patients who had a primary indication for intubation listed as angioedema. And then we generated a large table which essentially summarizes the observational findings for this cohort. And the reason why we did this is because very little is known actually about how often angioedema patients are intubated. If they get intubated, how are they intubated? What are the success rates? What tools are used? Who's doing the intubation? It was a little bit of an unknown. and honestly, not a very common occurrence, as you'll see. And this first table, actually, there's two slides because we had to cut the table in half because it was a big table, really represents the meat of the paper. So I will highlight the parts that you need to focus on. So you don't need to look intently for the key pieces of information. But the first thing to note is that of more than 19,000 intubations, only 98 were intubated with a recorded primary indication of angioedema. So that's 0.5% of the entire registry. So this is not a common thing to intubate patients for. What we observed was an overall first attempt success of 81%, which we thought was pretty good for patients who have some degree, sometimes a large degree, of airway anatomy distortion. Most of the intubations were being performed by emergency medicine PGY3s. And after the EM PGY3s, it was the EM PGY2s. So the attending turnout didn't do very many of them, and neither did interns. And that's probably the way most training programs work out, is that the senior residents do most of the difficult intubations. And the majority of the centers that contribute to NEAR are academic medical centers. The most common device that was used was a flexible endoscope. And after that, it was some variety of a video laryngoscope, with really direct laryngoscopes only being used a handful of times, and must be in cases where angioedema was very, very early, because otherwise DL really doesn't work in these patients. The other thing that was very interesting is that I would have thought that most of these patients would have been managed with awake techniques, which we'll talk about in the next paper. But it turns out that 60% of patients with angioedema who get intubated are actually intubated with rapid sequence intubation. And I'll talk about why that is in just a minute. So on part 2 of table 1, the things that are important to note here is that most of the patients were intubated orally. And now, as I think about this and the method that was used on the previous table, this might start to make sense, actually. Oral sedation with paralysis was the most common method. And the overall success rate was 99%, so 97 out of 98 patients were intubated successfully. 2 patients, which I don't think is bad, it's much higher than the entire registry, but you're dealing with someone with airway obstruction. 2 patients out of essentially 100 required surgical rescue. So things I found interesting about this paper: number one, I was surprised to find out that orotracheal intubation with rapid sequence intubation was the most common way that these folks were intubated. And I had always made the assumption that all of these patients, essentially by the nature of their disease, would have to be intubated nasotracheally and likely awake, almost certainly awake. And that's not what we discovered. Now, why is that? And that has a lot to do with some of the limitations of self-reported registries. The first, I think, is if you have someone who presents with tongue or lip swelling, it might be angioedema, but it might be anaphylaxis. And it was misclassified as angioedema. And that probably happened to a certain extent in this cohort. And the reason is that in the forced to act imperative, which I'll show you on the next slide, those patients essentially get RSI with a double setup. And forced to act means if the swelling or whatever pathology is going on is progressing so rapidly that you don't have time to do an awake technique. And so you're forced to give yourself the one best shot at intubating the patient, which is the patient asleep and relaxed with a video laryngoscope, orotracheally. And often, especially if it's early swelling but predicted to be progressing rapidly, the oral cavity may still be available to some degree to slip in a narrow profiled video laryngoscope and hope you get the patient intubated with immediate recourse to a surgical airway if that doesn't work. So I think the force to act confounder may be contributing to some of what we're finding here. The other interesting thing, which I didn't focus on, but I want to show you here, if you look down about halfway down the table, you're going to see nasal sedation and paralysis with an N of 12. Now that seemed super odd to us, and we mentioned this in the paper and talk about it. That would be highly atypical to nasally intubate someone with RSI. And what we think happened, and what we think we're observing here, is someone who has fairly advanced angioedema. The mouth is not available, so they plan to go nasotracheally. They initially have the patient topicalized and lightly sedated, perhaps, and they navigate the scope just to the top of the airway, or perhaps they just get the scope past the vocal cords, but they're in the airway and confident that they're in the airway. And maybe the patient starts reacting at that point, and they decide, because the scope is in the airway, at this point they feel like, and I'm not advocating for this, I think this is the wrong move actually, but they push neuromuscular blockers at that point. So before the scope comes out, they actually had administered neuromuscular blockers, but not until the scope was already at or in the airway. And it probably got recorded that way in the registry. So it's likely not a traditional RSI, but the meds were likely given in stages. If you look at and this is from our difficult airway course, this is the difficult airway algorithm. You can see how some patients with airway obstruction end up getting RSI drugs in an orotracheal intubation attempt, and some undergo an awake technique. So if you start in the upper left-hand corner and work your way down, you can see that second row is asking you whether you want to invoke the force to act imperative. And what that means is that if you feel like if things were progressing more slowly, I would prefer to do an awake technique, but I don't have time to do that. Whatever's happening is going to finish happening in 5 minutes or less, and I'm going to lose the chance to intubate this patient. In other words, the swelling is going to complete in less than 5 minutes, and there's no way I can properly prepare a patient for an awake intubation. So they get RSI drugs with a one-shot airway and hope that they're successful, and they move to a surgical airway should they fail. And then other patients, there'll be time, they'll be oxygenating okay, and awake intubation is the correct maneuver in patients where time is available. So it's not completely surprising, I guess, in retrospect, how the different angioedema patients broke out in those two groups. Now, as we go through the presentation, we're going to hopefully summarize each paper with a critical concept. And we're using this little caricature of me inside a C with a little 3 at the top, which is meant to represent Calvin's critical concepts. So when you see that in the upper left-hand corner of the slide, this is a critical concept from the paper that we're reviewing. So what's the C3 for this paper? C3 is airway management for progressing angioedema. The method that you use depends on the time available and the degree of obstruction. So when the patient is slowly progressing and there is time to topicalize and perform an awake intubation attempt, then that's the preferred method. However, if it is a rapidly deteriorating airway, and this is going to be a one and done type of intubation, then you need to give yourself the best intubating conditions possible. And that's with rapid sequence intubation using a video laryngoscope. So if there's time, it's awake. If there's not, it's RSI with double setup. That's the critical concept that we learned from this paper. Okay, let's move on to part 2 in our clinical scenario. So you decide that there is some time, and I agree, this has been going on for a couple of hours now, and the patient's starting to get some more serious symptoms, but the patient's not in extremis. So you decide to attempt an awake flexible nasotracheal intubation. But how do you do this? When was the last time you did an awake intubation? When was the last time you saw any of your colleagues do an awake intubation? But really answer this for yourself. When was the last time you did an awake intubation? Last week? Within the last year? It's been since I was in residency, whenever that was. For me, that would be many, many years ago. Or I've never done an awake intubation. Okay, so let's talk about intubating patients awake. And we had kind of a dual siloed submissions along these lines, one for airway obstruction and another one for awake intubation. This one happens to be in the American Journal of Emergency Medicine, was just accepted last month, I believe, for publication. Also comes from NEAR, so we don't have to rehash that. We know what NEAR is at this point. And we defined awake intubation for the purposes of this study as patients who received either topical anesthesia alone or topical anesthesia with subinduction doses of sedative. We did not include patients who received sedation alone, and that includes ketamine alone. And the reason that we decided not to include those because it was really too hard to figure out the intent of the sedation. There are lots of sedation-only intubations that are performed not because they're doing an awake intubation, but because sedation-facilitated intubation is how they were, how the practitioner was taught to do all their intubations. And so it was really hard to decipher which ones, if it was sedative only, which ones are really, they were sedated with the intent of doing an awake intubation, or those who were just, that was their standard practice. So we left them out just to keep the analysis clean. And so with that in mind, we selected for patients who received those two combinations of medications, either topical anesthesia or topical anesthesia plus sedation. And we also came up with a large table 1, which summarizes the key findings of the paper. And I will highlight the things that are important. So in contrast to angioedema, where a lot of patients were RSI'd, when you're talking about just awake intubations, most of those patients are intubated with a flexible scope nasally. They are also performed by senior level residents. And the reason why they are done nasally is because the vast majority of patients are being intubated for some degree of obstruction or some obstruction from some etiology, either anaphylaxis, angioedema, or airway obstruction NOS. That was the majority of patients. Now, our overall first attempt success was 85%. Now, the other thing that's very interesting is that we found a first attempt success of 92%. This is what was recorded in the registry for patients who were nasally intubated with a flexible bronchoscope. Now, that is very high. That's about what we observe for garden variety patients undergoing RSI being intubated with a CMAC. So we have an explanation for this, but we thought this was very interesting. And in retrospect, it probably has to do with how we define a single attempt with a nasal flexible scope. It's different than when you are intubating someone orotracheally with a laryngoscope. We know exactly what an attempt is. It's any time you open the mouth and insert a blade past the alveolar ridge. And if you come out and reinsert again, that's a second attempt. It's very unclear what defines a single solitary airway maneuver or attempt with a flexible scope through the nose. And that's probably why this number is so high. The other thing I want to call your attention to is when you look at the devices that are used, there's a whole bunch of them. There are flexible scopes, of course. The CMAC is used, a direct laryngoscope is used, glide scope is used, geez, blind nasotracheal intubation is performed, and intubation through an intubating LMA. So one important concept from this paper, and I'm going to skip forward for just a second, is that awake intubation is not about the device. People always think that an awake intubation means I have to use a flexible scope. And if I pick up a glide scope or a CMAC, that's not a tool that you use for an awake intubation attempt. And that's not true. It's about the approach. It's not about the device. Now, limitations specifically as it relates to the success rate we see with flexible intubations through the nose, that likely has to do with the definition of a single attempt with a flexible scope. So for example, if you go in with a flexible scope, you get down to the vocal cords, the patient coughs, and you have to retract and come almost all the way out of the nose again, and then reinsert. Is that a single attempt, or is that 2 attempts? Or do you wait until you have to change operators to define that as a second attempt? It's such an unusual device for emergency physicians to use. It's not strictly defined. And what we think probably happened is that people may have had 2 or 3 approaches to the airway, but never fully extracted the device out of the nose, and they counted that as a single attempt. Regardless, we think we're making headway, because when you look at old endoscopic intubation attempts and success rates from a previous version of our registry, looking at data going back from 2002 to 2012, although this was published in 2018 by Emily Hayden, this is in academic emergency medicine, it used data from a decade or 2 ago, where the overall success rate was 74% with a first attempt success rate in the 50s. So even though we may not have a firm handle on what our actual first attempt success is with awake nasotracheal flexible intubations, it's higher than what was previously reported for sure, and we are making progress, and has a lot to do with the tools that are more widely available and the training that people are getting now in flexible endoscopic techniques. So that brings us then to the next section of this presentation, talking about technique. How do you actually do this? Now, many of you, actually 40% of you, roughly, said you've never done an awake intubation. And so let's review, although this is not part of the literature, I think because we're talking about it, it'd be helpful to review how to get this done. How do you perform one of these? And we're going to focus specifically on flexible intubations through the nose for someone who presents with obstructing airway pathology in which the oral cavity is not available. So you have to go through the nose. Now, how do you get that done? So there's 3 goals when you are approaching a patient with who you're preparing for an awake intubation attempt. The first goal is to dry the airway. Anesthetizing the passages down to the glottic inlet, it's very, very difficult, if not impossible, with a wet airway. It's impossible with a bloody airway. So don't even try this with someone who's got upper airway bleeding. This is not the method for these patients. The second goal is to, if you're going to go through the nose, is nasal passage vasoconstriction that opens up the nasal chamber and limits the incidence of epistaxis. And of course, the last goal, the most important goal, is to provide airway anesthesia, and you can do this a number of ways. Primarily, you're going to be atomizing 4% aqueous lidocaine. You can also use a 5% lidocaine paste, which is marketed by a number of different manufacturers, but Lidodan is a very common one. And then viscous lidocaine around the endotracheal tube. Some of the things that you're going to need, we just mentioned. This is an image of a handful of things that you might gather up in your ED to do one of these. So first, up in the upper left-hand corner, this is what a typical bottle of aqueous 4% lidocaine looks like. It's a brown glass jar. If you don't have it in your ED, you can get it from your central pharmacy, and you should stock it in your Omnicell. The middle picture is lidocaine ointment, 5%. There's Afrin, which is a vasoconstrictor. You can use neosynephrine, but oxymetazoline's a little more potent. And then, of course, you're going to want to get some of your devices. I put the glide scope in there only because I wanted to remind you all that if you're going to go through the nose, you need a flexible scope, but you will intubate some patients, or you'll want to intubate some patients awake through the mouth. You can do it through the mouth. And so you can use a CMAC or a glide scope. In fact, and we'll talk about this in a minute, one of the common indications for an awake intubation, doesn't have anything to do with anatomy, is predicted dramatic and rapid desaturation. And if you predict that desaturation is going to happen instantaneously as soon as you give sedative medication and then follow that with neuromuscular blockers, then you should keep that patient breathing. And it doesn't mean they have bad anatomy. The mouth may be available to you, but you want to keep that patient awake for physiologic reasons. That's the main indication for doing awake intubation. We'll review that in a second, because the last paper is about decision-making around awake intubation and when to do it. You're going to need a mucosal atomizer device, because you're going to need to anesthetize the nasal passage, the posterior pharynx, so you can get the glossopharyngeal nerve, and then around the base of the tongue so you can spray the glottic inlet. You can see that the top one is just one of those cone foam mist atomizers that is really just good for doing the nose. And the semi-rigid laryngotracheal atomizer is in the bottom left-hand corner. This allows you to put a curve on the atomization device, which allows you to get around the base of the tongue so you actually can anesthetize the structures of the glottic inlet. All right, so here's the recipe for doing this. And it's good because this approach does not require any needles, which you'll love and the patient will really love. First is a drying agent. So once an IV is placed, you can give glycopyrrolate, which is also Rubinol, 0.2 to 0.4 milligrams. I go with 0.2. You need at least 15 minutes. Some folks would advocate for a little bit longer because it takes some time for that medication to make the mucosa somewhat tacky. When you're going through the nose, you also want to pick a nostril and provide 2 sprays of Afrin. In fact, it doesn't hurt to do both nostrils. And then once that is done, now nebulizing aqueous lidocaine is not mandatory. The droplet size from nebulization versus atomization usually means that most of that anesthetic is going to be delivered distal to the upper airway, down into the lungs. But I usually don't see a huge downside to doing it, and I'm also getting stuff ready, so I don't think it hurts. You're not going to make someone lidocaine toxic because this is all topically applied and only a fraction of it gets absorbed. After you've nebulized, 4% aqueous lidocaine atomized along the entire passage that you're going to attempt intubation. So that means through the nasal chamber, posterior nasopharynx, the pharynx, the hypopharynx, and the glottic inlet. And then the last thing is to take about 1 inch of lidocaine paste on a tongue depressor, pull the tongue out with gauze, and spread it on the back of the tongue, almost like you're spreading jelly on toast. And then that liquefies in the warm, humid environment of the posterior pharynx, and that dribbles down and anesthetizes the glottic inlet. So that's the recipe that I use, and everyone's got a slightly different variation of this, but this will get you 95% of the way. Now, once this is done, what are the actual steps in doing it? How do I scope the person? Where does the tube go? This is a very, very important slide. You have probably seen folks intubated flexibly through the nose with the scope with the ET tube up on the scope so that the bag adapter is wedged on the tapered part of the body of the scope. I would recommend not doing that. What you should do instead is take a 6.5 ET tube, might be a 6 depending on how big the patient's nose is, and you want to blindly insert that with lidocaine jelly around the outside. Now remember, you've already vasoconstricted and anesthetized the nasal passage, and put it into the nose about 12 to 14 centimeters. And in most adults, that's going to put the tip in the posterior nasopharynx. With the tube in place, you can simply push the scope through this tube, and as you come out the other side, you can see that the light is glowing from the end of the scope in this cartoon image, and you should be looking right at the vocal cords. So it gives you a snot-free channel all the way to the airway. You don't have to worry about maneuvering the scope through the nose, getting underneath the turbinates. The most important thing, though, is you've already proven that the ET tube can fit through that nostril. So if you go through the hassle of scoping someone through the nose, you facilitate scope passage past the vocal cords down to the carina, and now you're going to try to advance the tube, it would be such a shame to realize only at that point that the ET tube doesn't fit through the nose. So put the tube in first. Okay, so this brings us now to our last paper. We've talked about intubating patients with angioedema, how that's done. We've talked specifically now about how often awake intubations are done. And by the way, awake intubations are only performed, I didn't mention this, they're only performed 0.4% of the time. So, less than 1 in 200 intubations in the ED is done as an awake intubation based on our definition. So if you are someone who's either done this rarely or has never done this, you are not alone for sure. But there are clear indications when an awake intubation should take place, and that's what we're going to review now. So the last paper is entitled Canadian Airway Focus Group Updated Consensus-Based Recommendations for Management of the Difficult Airway, Part 2. Part 1 was about how to manage a difficult airway that you stumble upon, and now you have to, in a hurry, figure out a plan for safely managing that patient. But let's say you have time to do a full airway assessment and construct a plan. What's the thought process around this, and when should I be doing rapid sequence intubation with double setup versus an awake intubation? Now, this is a very long paper. There is a lot to unpack from this paper, but essentially the entire paper is summarized by this. In fact, all of the words embedded in that paper is designed to tell you how they got to this algorithm. So you can essentially summarize the paper by looking at this. And it's a variation of the algorithm I already showed you, but I kind of like the questions that they ask, so I wanted to show you. You're at the bedside, you start in the upper left-hand corner, you're looking at the patient, and difficult tracheal intubation is predicted. And that's initially based on the patient's anatomy. Are they in a C-collar? Do they have a big head and neck infection? Is there an expanding hematoma? Do they have angioedema? Do they have a gunshot to the face and they have altered anatomy? Is there profuse bleeding? So you ask yourself first, is an awake tracheal intubation clearly indicated? And probably a better way to ask that, at least for folks who do either pre-hospital medicine or critical care or emergency medicine, is by looking at the patient, can you just tell by looking at them that laryngoscopy with a rigid handheld blade is going to be unsuccessful? Like 98% sure it's going to be unsuccessful. So a patient with super tight angioedema, for example, their mouth is already pushed open by a swollen tongue. The entirety of the oral cavity is taken up by real estate from this swollen tongue. And there's just no way you can get a blade past the obstruction, for example. Then, yes, awake tracheal intubation is clearly indicated. So you move down to where a lot of these arrows end up pointing, the diamond over to the right, and you ask yourself a couple of questions. Can the patient cooperate? I don't think that's as critical because you can make the patient cooperate with ketamine. But the most important question is there time, right? This is a time-dependent question because if you had time and awake tracheal intubation is indicated, you would do an awake tracheal intubation. But giving glycopyrrolate, topicalizing the airway, navigating the flexible scope, passing the tube over this, I mean, that all takes time. You're probably looking at 20 minutes at least. So if you don't have 20 minutes, then you have to proceed down to the bottom, which says basically your one-shot airway, which is RSI with double setup. And then you can move yourself down the algorithm. So if awake tracheal intubation is not clearly indicated based on anatomy, you ask yourself, am I likely to get in trouble with rescue oxygenation? Right? They say something slightly different. You're predicted to have difficulty with face mask ventilation or supraglottic airway use. But what you're really doing if you give RSI meds and you can't get the tube and the patient desats, you have to have a reoxygenation plan. And your reoxygenation plan is going to involve either a bag and mask device or a supraglottic airway. And if you think neither of those are going to work, or they're going to be significantly difficult, then again, you move over to that other diamond and ask yourself, this is an awake case. Is there time to do an awake case? If there is, do it awake. If there is not, it's RSI with double setup. And all of those questions in that left-hand column basically all send you to the awake intubation diamond. And the key question there is there time? Now that I've recognized an awake intubation is the way I would manage this if I had all the time in the world, do I have all the time I need? And if the answer is yes, do it awake. If it's not, double setup. So when you are seeing your next airway in the ED, or I think it's really hard to do an awake intubation in the pre-hospital setting in the way we've described, but you might go through this checklist and ask yourself these questions, and you'll come up with the right strategy. So I decided to think about this in a slightly different way. I've described it the way that they mapped it out on their algorithm, but what you're really asking yourself, and this is a critical concept, is what is your LA ratio? That's a term I just made up. I don't know if it'll work, but it seemed to work in my mind. L is the time needed to perform adequate laryngoscopy. And the A is your safe apnea time. So if you have a positive L to A ratio, where your laryngoscopy time is predicted to be much longer than your apnea time, then that's a bad ratio. If it's the other way around, where laryngoscopy is not going to take very long because it's a very straightforward anatomic airway, and it's a patient who's easy to pre-oxygenate, and if they desat, I'm very confident I can reoxygenate them, then you have a beneficial L to A ratio. So think about your laryngoscopy to apnea time ratio. If the anatomy is going to make laryngoscopy challenging, it's going to take a long time to get to view the airway, and it might take a long time to place the tube successfully. If that's going to be longer than the predicted time of safe apnea, then you are likely going to end up in a can't intubate, now hypoxic situation. So that'll tell you whether you should do it awake or not. Awake intubation is indicated with prolonged laryngoscopy and short apnea. And now we're going to move on to an eerily similar post-test. All right, post-test question number 1. In the emergency department, angioedema requiring intubation is primarily managed with which tool? Hyperangulated VL, flexible intubating bronchoscope, direct laryngoscope. All right, so 72% of you think flexible intubating bronchoscope, and correct. All right, next question. Which of the following is true about awake intubations? Most are performed by non-EM specialists. They represent 3% of all intubations. I just gave you another number. The orotracheal route is most common, or airway obstruction is the most common indication. Ooh, okay, you guys scared me there for a minute. I thought you were going to end up mostly choosing the wrong answer, but I think we just saved it. Right, so even though you certainly can intubate patients awake orotracheally, what we found in our registry is that airway obstruction of some variety was the most common indication, and therefore they were mostly intubated nasotracheally. Post-test question number 3. All of the following are indications for an awake intubation in the ED except, this comes right from the algorithm we just went over. Significant anatomic distortion, predicted rapid desaturation, poor preoxygenation due to intrapulmonary shunt, or need for immediate intubation. You can also think of choice D as saying the same thing as forced to act. All right, good job. Yes, need for immediate intubation. If the tube has to go in 5 minutes or less, then a properly performed awake intubation is not going to be the way to go. Okay, and post-test question number 4. An awake intubation means the patient is intubated without medication, intubated with sedation only, intubated with topical anesthesia, with or without token doses of sedatives, or intubated with heavy sedation, but small amounts of neuromuscular blockade. An obtunded patient who's partially paralyzed. Whoa, we have never had this happen ever in an Airway World webinar. We've never had 100% of the audience choose the same answer and have that answer be the correct answer. So congratulations, nice work. Thank you for paying attention. All right, well, what I'm going to do right now before I make any closing statements is I'm going to open up the chat box here and see if we have any chat or questions. Okay, so Rebecca asks, is a double setup VL plus fiber optic or VL fiber optic plus Crike? That's a great question. In my mind, in emergency medicine, the double setup means your primary intubating method plus Crike. So for the force to act, essentially, or if you are going the RSI with double setup, this is really rapid sequence intubation because it's a one-shot airway. You're going to use your best tool for intubating, which is likely going to be VL. It's your most experienced operator, and if that fails, you move to Crike. Great question, thank you. James asks, any comment on multimodal? James, tell me what you mean. Are you talking about using video with a flexible scope? Put it in the box there so I can understand exactly what you want me to comment on. And then, so while James is doing that, Anand asks, any role for Thrive? And by that, I assume you mean humidified transnasal, essentially high flow nasal oxygen. And I would say yes. A lot of us now, if we have an awake intubation that we're going to do orally, we will leave patients on humidified high flow nasal oxygen to support them during the intubation attempt. Yeah, so James asked, yes, confirm, VL plus flexible. So I'll tell you what, I have done that. I have taught that when people have asked about it at the airway course, but there's not a lot of evidence to support that as a primary management option. But I think that as these tools become more widespread, we will learn more about it. And that is something that we are going to study, or at least observe, and then report on in the next version of our near registry. That's a great question. Peter asks, is a drying agent even necessary if you're going to place a scope through a 6.5 tube by the nose? And I would say yes. And the reason is, once you get, in my mind, once you get out of the end of the ET tube and you're looking at the top of the airway, you still have a small amount of distance to travel. Often the secretions are pooled there. And you still need to do the anesthesia piece. So the drying agent is both to get rid of a lot of the secretions that will be in your way visibly, but also allows more dense and more effective topical anesthesia. And Jeff asks, in the pre-hospital setting with 4% Lido not available, how effective do you think 2% Lido nebulized or applied with a mucosal atomizer device would be in an awake scenario with ketamine sedation? Well, it's going to be different because standard 2% lidocaine that's not an aqueous preparation doesn't it won't work exactly the same. It tastes very sour to the patient. So in bottom line is, I don't think that's been studied and I don't know, but I think it's better than nothing, but it's going to be pretty toxic to the patient. They're not going to like it. It's going to be more of a ketamine facilitated, intubation attempt than topical anesthesia. If you have a patient with wet airways as well, or bloody airways, and you don't have a drying agent, that will make it even harder. So I wouldn't lean on that. I think you could try it, but I wouldn't lean on it. It's going to be more of a ketamine facilitated intubation attempt. Great question though, Jeff. Thank you. All right, great. Well, that looks to be all the questions for now. I would like to let everyone know that a recording of this webinar will be available as a podcast in Spotify, Apple Podcasts, and wherever you get your podcasts. Just search for Airway World Podcasts. You'll receive a webinar certificate by email within 3 weeks. Our next webinar will be on December 16th. That will also include the annual Article of the Year award show, where you, the audience, selects the best article from the nominees. It looks like we don't have any more questions for now, so I thank everyone for joining us today, and thank you for being flexible. I know I changed the date at the last minute. I had something unavoidable that I couldn't do the 23rd, so thank you for being here on the 30th, and we will see you in December. Everyone have a terrific fall.